Good afternoon, distinguished guests and colleagues. My name is Jenelle Krishnamoorthy, and I'm pleased to be with you today. We are convening a critical moment for public health. This week, the attention of our community is focused on the burden of non-communicable diseases at this year's UN high-level meeting. Cardiovascular disease remains the leading cause of death across the globe, but as many as 80% of premature heart attacks and strokes are preventable. Too little attention is devoted to addressing this modifiable leading cause of death. Too few countries have dedicated national cardiovascular health plans, and cardiovascular disease remains underfunded within national health budgets. The gap between what we know, what works, from cholesterol management to tobacco cessation and hypertension control, and what countries implement has costs in lives and economies. Today's session is designed to call attention to that gap. We will highlight tools and evidence that strengthen the investment case for policy action, and we'll hear what is already happening to advance these efforts. It's my pleasure to introduce this distinguished panel. The Honorable Eirini Agapidaki, Alternate Minister of Health of Greece. Also, Borjana Pervan, the COO of the World Heart Federation, and Skedgel, Director of the Office of Health Economics. Let me begin with you, Ms. Minister. The ministry has taken important strides in prevention, including the recent rollout of a free heart health checks, which have already reached, this is unbelievable, more than 1.8 million people, and are described as the largest public health investment in 4 decades. What lessons can other countries take from this experience on how to design, finance, and scale a cardiovascular health programs that are both impactful and well received by your constituents?
Thank you. Good morning, everyone. It's a unique opportunity to be with you and be able to share our experience. I won't stand a lot on the epidemics. You set the scene with the data. I will try to give you a snapshot of what we've been doing in Greece. In February 2025, we have the opportunity to launch a population screening program, a general population screening program. It's universal, free access for citizens aged from 30 to 70 years old, because we have a large contribution in premature deaths on these age groups. So we have also fully digitalized our prevention program. So we call it prolambano, it's a Greek word, which means that we take action beforehand. So for the very first time in such an over-medicalized system like the one in Greece, we take action in terms of prevention for primary, secondary, tertiary prevention. This is a secondary prevention program. So far, actually, according to the latest data, 2.2 million people have already screened for cardiovascular disease. The program has 3 steps. We have already identified more than 7,000 people with ischemia. They proceed to the next steps. They take therapeutic procedures and everything. So at the first step, we have the blood test for lipid profile, then the medical consultation for cardiovascular risk and metabolic syndrome, and when indicated, the cardiology evaluation, including the lipoprotein A, echocardiography, etc. And at the third level, we have the advanced diagnostics for ischemia, for example, stress echo, contrast echo, or other diagnostic procedures. We wanted to identify as many people as possible with what can be called as risk factors or diseases, which is hypertension, diabetes, etc., and manage these conditions in the community. Otherwise, we understand that these people will end up to the cardiology clinics with a heart attack or another implication of the disease. Projections for Greece suggest that up to 20,000 deaths from heart attack or stroke can be prevented for every million citizens screened. I think I should not take more of your time. I mean, we set the scene by this evidence alone. So that's why we invent so much on prevention. Later on, we will have the opportunity to elaborate a little bit more. Just one more element. Every euro spent on this screening is justified by the lives saved, the hospitalizations and deaths avoided, and the subsequent increase of workforce productivity, which is very important given the fact that Europe, we have an aged population.
Well, thank you very much. Your leadership in taking these steps is very inspiring. Let me turn to Borjana. So thinking about the UN high-level meeting on NCDs taking place tomorrow, how can the World Heart Federation help take forward the political attention on NCDs to make cardiovascular health a priority for governments, similar to what we've just heard from that's happening in Greece?
Thank you, Jenelle, and good morning, everyone. It's a great privilege to convene this session that is dealing with the world's deadliest, but also most preventable cause of death. That's cardiovascular disease. In the next 20 minutes, 780 people will die from cardiovascular disease. Just think about that number. And think about that we, together with governments, with industry, and with research institutions, united by federations such as ours, we have the knowledge, we have the power to change this. What we will be bringing to the UN tomorrow is a very specific set of asks that start with cost-effective measures that countries can implement in their settings and adapt to their settings, and that are proven to already have impact, such as screening, such as hypertension screening and treatment. So we're asking for a 50% reduction in hypertension by 2030. And we know, we've calculated that it will save 75 million lives. And the cost of it in economics revenue is 220 billion. So again, when we talk about lives saved, we have to not only talk about the cost of inaction and how stern and somber this message is, but also the cost of opportunity and revenues. And then the other important ask that we're bringing forward to the UN is the 50% taxation on unhealthy products, tobacco, alcohol, and sugary drinks that will bring money and strengthening the system, and that will enable countries to have the budgets and the sustainable funding necessary to take forward measures such as what you're doing in Greece, and that's very commendable. And lastly, what we are doing on a very practical side, and after tomorrow, because there is a life after tomorrow, and I think tomorrow is actually just the beginning and the basis of what we're trying to achieve. We will be working with countries, with our societies, with our federations, with governments, with entities in countries, to identify where is their biggest burden, and to promote the investment in cardiovascular health plans. And just one last number, we did an assessment of all WHO member countries, and it's only 16 of them that have standalone cardiovascular health plans. That's 8% of them, versus 80%, more than 80% who have cancer plans. And we need to also look at what the cancer control plans have taught us. And we might not see immediate in a political cycle of 5-year impact, but we will see that means that countries identify the gaps and then allocate funding and identify partners.
No, thank you very much. And I do think it's important what you were talking about, sustainable funding, because it takes so much to stand up these programs, but then you need to keep investing in them. And I'm so pleased to have Dr. Skedgel with us right now, because research and data, as you're hearing from everybody here, is the foundation of what we need to then build the case and advocate for these kinds of measures. And I know you have been leading some important research that provides us new analysis to understand the impact of cardiovascular disease on health systems and societies. Can you share a little more about those findings, please?
Thank you. I'd be happy to. It's a pleasure to be here on the stage today. It's become a cliche already, I think, that we need to look at health as an investment rather than as a cost. And as the minister pointed out, prevention has payoffs in terms of costs avoided and lives saved, but there are a lot of competing demands on government budgets. The speaker before us was pointing out that that goes beyond just health. There's defense, there's technology, there's a countless number of demands on government budgets these days. So if we're going to make a claim, make a case for investing in this sort of prevention, we need some numbers, we need some economic analysis to back up the value of prevention relative to the other things that we could be spending that money on. So as you pointed out, OHE is doing some work around this. I'm going to keep this at nice round numbers because they all work out quite nicely for me, which is fortunate. So we've looked at the burden of atherosclerotic diseases. So those are diseases associated with plaque buildup in our veins. 250 million disability-adjusted life years lost every year. So disability-adjusted life years, that's an economic concept that we like to use because it combines the effect of illness as well as the effect of death. So we're trying to get an overview of the health impact. So that's 250 million DALYs each year and $750 billion US across the world in terms of direct costs to medical care systems. 1/3 of those numbers is related to uncontrolled LDL cholesterol or elevated LDL cholesterol. So to the extent that number, 1/3 of those cases, so fortunately when I say $750 billion for the overall cost, 1/3 of that, we're still down to $250 million spent each year on LDL-related care for people with atherosclerotic cardiovascular diseases. And to the extent that cholesterol is manageable with widely available medicines, that burden is largely preventable. So that's a pool of resources that we're spending that in some respects we don't need to, and we can repurpose that for other things. We've taken that global analysis that we've done and we've drilled down in countries just that have better data that let us have a look in more detail. So we've looked at 9 more developed countries, US, Canada, UK, Netherlands, France, Germany, Spain, Italy, and Japan. Across those 9 countries, we've found that the indirect costs of heart disease are twice that of the direct costs. So I've said we're down to $250 billion associated with preventable LDL-related, largely preventable diseases. When we factor in the indirect costs, we're back to $750 billion just across those 9 countries. So I think that makes the investment case that governments need to be able to justify those investments in prevention.
Absolutely, absolutely. Thank you so much for highlighting some of these findings, and everyone should go look at your report and see some more information in there.
Pending, but we hope to have it out as soon as possible.
I'm optimistic. We've heard, and we're down to 5 minutes here, these sessions go so quickly, but we've heard how evidence, financial resources, and political leadership all play a critical role. I'll ask all of you to give me your perspectives on what do you see as the biggest barrier to bringing these elements together to establish a well-funded national or global cardiovascular health agenda, and how can it be overcome? And you're speaking from experience of how you have overcome it, so if you have some best practices, I think that would be really helpful.
Okay, do you think that data can actually convince politicians to take action? Okay, I got my answer. So, yeah. Look, from where I stand, because I've been working for years at the academic sector, I'm a public health professional, so it happens to be and to serve as a Minister of Health. And my portfolio has to do with prevention and health promotion. So it's easy for me because nobody has to convince me about the value of prevention. And luckily, I hadn't to convince my Prime Minister because he was deeply aware of the value of prevention. So this has facilitated me a lot to go out the interministerial collaborations, intersectoral collaborations, etc. I think that we must think beyond the governmental cycle. I mean, for me, what's the most important thing is to build the toolbox, the framework, the ecosystem for the person that will take office after me to continue this work. Because I know from my academic experience that if you want things to continue to happen, and for me it was of huge importance to have finally horizontal, universal screening programs for free for anyone in Greece. So I have been working the last few months with my team to build the toolbox for the person and safeguard the funding. It's already there for the person that will be in this position after me. And luckily, I have at the highest level the commitment of the Prime Minister that we will continue this way. So it's important because we will screen not just the adults, but in case of parents, also their kids for LPA. In case that we have high LPA levels to the parents, we screen the kids as well. We have more than 15,000 places around Greece, including mobile units to try to tackle the geographical barriers because, you know, in Greece we have the small islands, the mountainous areas. We have a new AI service that will be launched in March 2026 for pre-screening for cardiovascular disease. So you get individual plans, reminders, and everything can forecast when you should be screened, where and why, and follow up, and you gather all this data to your electronic medical records accessible from different specialties, different health clinics, and also for the patients as well. We are actually in the middle of a reform for health data. We will have open access databases for researchers, for pharmaceutical companies, for different partnerships and players to make good use of this data and try to provide more evidence, not just for politicians, but also for policymakers, and try to bridge the gap a little bit between policymakers and politicians. We provide quick wins, but we need also to think beyond the governmental cycle. My 2 cents.
No,
Lots of here.
very good, and really applaud all of your efforts in moving this forward and thinking about the future, not just right now. So in just a minute, can you give me your top thoughts on this, and then to you, doctors?
So the biggest challenge is to translate evidence into action, and to do that, data is not enough. To do that, you need to empower people and communities with the knowledge, but also with the passion that you as an advocate for cardiovascular health can bring to them. So don't be afraid, and that's what we're trying to do at the World Heart Federation, to speak outside of the borders of health, to go and reach to the climate sector, to go and talk to the humanitarian sector first. Second, don't be afraid to not just talk about data, but to show very well the lives behind each of these numbers. And thirdly, when we speak about policymakers, we often think of them as some species who don't understand another language but data, and that's absolutely wrong. So of course we need evidence, we need the data, but we need to relate at a human level to people. That's how you reach people, that's how you motivate people to change. Right. And last, find people where they are. So don't necessarily wait for them to come to you, because those that are most vulnerable, they will not be knocking at your door. Sorry. Those that are most vulnerable, you have to reach to different channels, including digital channels. You have to go and speak to and reach the young people, because that's whose lives you want to protect and to ensure a healthier future. For every single country in the world, the health depends on the most sick person. That's how the healthy country is, as its most sick member of the society. We each have to be healthy to be able to have a healthy future for everyone.
Thank you. Dr. Skedgel.
Very briefly, move beyond the health argument to make the fiscal argument. Prevention keeps people out of the healthcare system and in the labor force. That's, to me, the next frontier in making that case.
Absolutely. Thank you, Dr. Skedgel. I want to thank this incredible panel here, also the World Heart Federation and Concordia for bringing us together. Through our collective efforts, the next time we meet, I think we should endeavor to be able to discuss measurable progress, fewer heart attacks and strokes, stronger healthcare systems, and the concrete policy and financing decisions that have made it all possible. Thank you very much.
Thank you.